colleague. This is another miscellaneous cases session. Take care, my colleague. This is simulate nearly the exam. Okay. It is about 6 to 7 cases, nearly the same as the exam. It contain all system with different degree of difficulty. Um, okay, but take care from subtle finding. Today is a session of subtle finding and satisfaction of search, and this is very important in our exam. Our first candidate, please mute yeah, my colleague. Please mute yourself, all of you except the candidate on the hot seat. Okay. Candidate one, you can unmute yourself.
Yes, sir.
Yes, unmute. Yeah. This is a 9 years old patient complaining of mental impairment. You have the mouse and you can go.
Okay, sir.
What's it? Yeah, go. 9-year-old
Yes,
patient with mental impairment.
yes, sir. I'm provided with MRI brain T2 weighted images of a brain um, plane, and I am provided with a history of 9-year-old with mental impairment. I will first scroll through all the images, and
Okay.
then I will start from here. So here I can appreciate that there is moderate to gross hydrocephalus. The both lateral ventricle, third ventricle are dilated, and there is T2 hyperintensity in the white matter is also noted, and there is reduced cortical thickness, and this hyperintensity is extending to the subcortical white matter and U fibers as well. I am looking for the cause of obstruction of this, and I can see that there is dilatation of the fourth ventricle and posterior fossa CSF space, and there is mild right-sided mastocytosis as well. I am scrolling down till foramen magnum to look for any obstructive cause at the foramen of magnum or below that, and I couldn't appreciate any obstructive cause of this hydrocephalus. There are no gross tonsillar herniation below the level of into the upper cervical canal, and the midbrain and pons appear normal. Cerebellum has normal volume. Midline vermis is normal. So, can I see FLIR images to further confirm my findings? On FLIR images, there is re-demonstration of all the findings. The white matter is showing T2 hyperintensity, and so keeping in view the finding, this is a case of communicating moderate to gross hydrocephalus. As no obstructing cause is visualized, so I would like to image the entire spinal canal to look for any low-lying spinal cord obstructive lesion, and this can be a case of post meningoencephalitic sequel in which there is moderate hydrocephalus, and I would like to take if there is any history of previous infection or previous any history of fever
Doctor,
for which patient.
could you have a look again here? Do you think this is hydrocephalic changes or something else?
Sir, basically there can be two pathologies. First is these can be the hydrocephalus secondary to the post meningoencephalitic sequel with marked volume white matter contraction. And the second is the possibility that there is diffuse white matter disease that can secondary lead
Yes.
to the dilatation of entire ventricular chain and extraaxial CSF spaces with white and gray matter contraction as well. So, if there is no previous any history of meningitis or encephalitis, the possibility of white matter disease that has led to these brain parenchymal atrophy. So,
Yeah, excellent,
I
excellent.
yes,
Okay. What?
uh,
Mhm.
they
So, which pathway you should run through it? Cephalic
have.
changes or something else? In your opinion, give me
Yeah,
يعني one of the two different differential diagnoses that you mentioned.
sir. The vanishing white matter disease can have this appearance. I couldn't recall the white matter disease right now that leads to such marked ventricular and extraventricular CSF space dilatation. Um, so, can we perform further the MRIs of this patient to characterize in which lipodystrophy the patient can uh, go? The MRIs can further help us.
Is interrupted. Hello?
Yes, sir.
Yeah, yeah, yeah. Why is what you said? Hello, doctor.
Yes, sir.
Again, you
Yes,
are talking about two different entities. Okay?
yes, sir. Yes, sir.
Please give me يعني one of the two differential diagnoses. What is
Sir, the
your
only thing, yes,
yes?
yes, sir, the only thing I can recall right now is this in the spectrum of lipodystrophies with extensive white matter disease. I would like to proceed it further with the magnetic resonance spectroscopy to delineate or to narrow down the differentials. I
Okay, now
couldn't recall any
my
name right
question.
now.
Do
Yes,
you
sir.
think this is hydrocephalic changes or just ventricular dilatation?
Sir, this
I
is,
mean, I
yes,
mean hydrocephalic changes due to increased intracranial
yes,
tension or just
yes.
the ventricles enlarged.
Sir, I guess this is only the ventricle enlargement.
How could you
Sir, I,
differentiate between both entity?
sir,
Hydrocephalic changes due to increased intracranial tension or ventriculomegaly due to other causes.
sir,
In your routine practice, how could you differentiate?
sir, radiologically, first we can identify the cause. If there is any ventricular dilatation secondary
One
to
word,
some
doctor.
pathology,
Doctor,
uh,
doctor,
sir,
one
there
word.
is,
From this
sir,
slice. Hmm.
from this side, there is a
Hmm.
trans ependymal CSF leakage is a thing which can say that this is under
Okay,
pressure. This is
from this case, doctor, do you see
yes, sir.
any CSF permeation? Look.
No, sir. No, there is diffuse
Okay.
white matter signals.
Okay.
Yeah, I
Okay.
can
There are
appreciate.
something more easier than CSF permeation or transependymal CSF permeation. Look at this slice. By the way, you are in the correct pathway. But, but give me the answer of this question. Look at this slice. What happened for the sulci here? Is
Sir,
it effaced
sulci,
or the sulci is opened? See, look,
sir,
look at
sulci
the
are open.
Sylvian fissure
Yes.
opened. Okay,
Yeah.
so there are no increased intracranial tension. Okay,
Okay, sir. Okay, sir.
so this is not hydrocephalic changes. This is a ventriculomegaly. Number two, what about the white matter and the brain overall? Is this atrophic brain or normal brain? Overall,
Atrophic.
look.
Oh, atrophic brain.
So the brain parenchyma atrophied and subsequently the ventricle get dilated. This is the
Yes.
cause of what we are seeing now of ventriculomegaly. Number three, what about the fissures here? Could you think this is normal Sylvian fissure? See?
No, sir. This is markedly expanded Sylvian fissure.
Excellent. So we are dealing with a case of increased intracranial tension or marked brain atrophic changes.
Marked brain atrophic changes secondary to some
Excellent.
leukodystrophy
Okay.
matter disease.
Okay. Connect what I said with your finding. What about the white matter disease? White matter
So,
disease, ventriculomegaly,
yes.
and atrophy. It equal
Uh,
leukodystrophy,
Sir,
like you said. But which type of leukodystrophy? Which leukodystrophy cause this يعني incredible ventriculomegaly? And look at the brain size, the skull size. What about the size? Is this
uh,
acceptable for 9-year-old?
no, sir.
So
So,
what is the
sir,
name of this sign? Enlarged
so,
skull and the brain. And what is the name of this sign?
Sir, the skull is bit elongated, so this can be in the spectrum of schistocephaly, which is elongated boat-like skull. But these are usually associated with the craniosynostosis. I would like to see if there is any 3D of the bone is available, but I couldn't
Okay,
recall the name of the leukodystrophy right now because
okay.
things
Are
which I
you will you agree with me if I told you this is megaloencephaly or megalocephaly? Would
uh,
you accept
mm,
or not? Hmm.
doesn't seem to doesn't seem to me.
What?
Sir, these
Hello?
doesn't seem to be sir, I don't know whose mic is
Please,
on.
my colleague, mute yourself. Okay. See, number another question. See, what about the Virchow open spaces here? Look, what happened
Yeah.
for these spaces?
Sir,
Is
these are
this
dilated.
acceptable? Excellent.
No, these are not
Which,
acceptable.
what?
Sir, these are not acceptable for this age group.
Excellent. So, which leukodystrophy cause all this finding?
Yes,
Enlarged
sir.
prominent?
Yes, yes.
Mm,
The mucopolysaccharidosis spectrum is causing the Wilker open spaces enlargement. Yes, I can
more
remember.
than excellent. More than excellent, doctor. Thank you so much. Take care, my colleague. This is a 9-year-old. So, this is not acceptable to see this size of skull. Megalocephaly. Number two, if you see this marked ventricular dilatation, don't say hydrocephalic. Hydrocephalus, all of us يعني, named it under increased intracranial tension. But if you told this is a ventricular dilatation, this is a better word. Why? Because here the dilatation is caused due to brain atrophy. Number three, there are a leukodystrophy. What is the difference between my doctor
Yes, sir.
leukodystrophy? Uh, okay,
Yes.
or sorry, desmyelination and demyelination. What is the difference between desmyelinating disease and demyelinating disease?
Sir, dysmyelination is basically the malformed white matter, which may be secondary to some
Excellent,
metabolic causes or some congenital causes. But the demyelination is the
excellent,
abnormal or disrupted myelin secondary to some infection or some metabolic cause after the brain myelination has completed.
excellent. What will you do for this patient of mucopolysaccharidosis?
Sir, we will refer the patient to the pediatrician for the correction of the underlying metabolic disease. I don't know the
Okay.
details, but when the
What else?
metabolic cause will be treated, then this can be
What
reversed.
else? What else
Sir, if
do
this is
you
a
want
patient
to
of
do?
mucopolysaccharidosis, we can go for skeletal workup of this patient as anterior vertebral body beaking in the spine and as well as
Excellent.
atlanto. and the bilateral hand radiograph will be helpful in that for further characterization and narrow down the type of microcephalosis.
Excellent. And abdominal ultrasound. For what?
Yes. Hepatosplenomegaly, I guess.
Excellent. Thank you, doctor, so much. It was a case of mucopolysaccharidosis, which is characteristic by extensive white matter disease and very characteristic. Look here at the basal ganglia, my colleague. See, all these holes, cystic changes, whatever, consider whatever you want, but this grabs like cystic changes. It is dilated vertebral space, and it is very pathognomonic, very characteristic of mucopolysaccharidosis. Plus the marked ventriculomegaly, plus the atrophy. Atrophy. See, the fissures is incredibly dilated. Looks, look, there are nearly no white matter here. White matter is totally atrophied here. Okay, plus the ventriculomegaly workup, including number one skeletal survey, including even the hand and the forearm for for uh, for bony changes, as well as the vertebral column anterior peaking. Number two, abdominal ultrasound. Number three, chromosomal study. Number four, family counseling, genetic counseling, because this is a hereditary disease. Mucopolysaccharidosis, I don't know if there are any correction or not, because this patient get his life mentally retarded forever. Yeah. Thank you, doctor, so much.
Thank you,
Next
sir.
candidate. Thank you. By the way, I bring this case especially for two issues. Number one, how to differentiate between ICT and atrophy. Number two, to pick up this vertebral space dilatation. Candidate number two.
Yeah. Assalamualaikum, sir.
Wassalam. Doctor, this is 60-year-old male patient has a right-sided lower limb pain. Can you scroll or should I
Okay.
scroll for you? Request
Um,
control.
yes, sir, please scroll for me. So this is an
Okay.
MRI image, and I can appreciate that there is a heterogeneous hypodensity mass with internal hyperintense signal.
What is the name of this sequence?
Sir, this is a T1 axial sequence,
Okay.
and I can appreciate that there is a heterogeneous mass with internal predominantly hypointense with internal hyperintense signals. It is posterior to the femur. It is involving the muscle.
Okay. Look at this sequence.
Okay, this is a
Okay.
T2 weighted sequence, and I can
Yes.
see that there is this mass appears. Mass has internal cystic areas which are hyperintense on T2 with the hypointense areas also. Uh, so this is likely an intramuscular mass lesion uh,
Okay.
with internal areas of hemorrhage as well as there was few hyperintense areas on T1 as well.
Yes. What else?
There are few levels in it also,
Okay.
fluid levels.
Okay.
So this is likely a malignant lesion.
Okay. Give me definition.
This could be a malignant fibrous histiocytoma. This could be a
Okay.
sarcoma.
Okay.
Further, I would like to inform the referring physician and refer this patient to sarcoma center for biopsy for exact diagnosis and further management in sarcoma MDT.
What is the name of the sequence?
This is the FATSAT sequence, and this lesion is hyperintense on this
Okay.
sequence.
What is this?
This is a hypointensive. This is a fat-containing lesion. Okay, this is a fat-containing lesion. So this is a
One second, one
liposarcoma.
second. Are you sure this is fat? Look here and look here. Again.
This could be hemosiderin.
Okay. What is your next step, doctor? In any skeletal lesion or MRI examination, what is your next step?
So next step is to include both the joints, proximal and distal, to see any skip lesion,
What else?
and bone scan to see any metastasis or any companion lesions.
What else?
Um,
Yeah. What else?
uh,
You see something and you are in a doubt about this. What else? Do you want to
mm.
revise anything for this patient? Anything?
Sir, is there any X-ray? I would like to see X-ray of this patient.
Okay. This is the X-ray. What do you think?
Okay, on X-ray, this is I can see an oblong lesion with a hyperdense lesion, and it is separate from bone, and I can see lucency at its apex. So,
Yes.
so this can be a case of dystrophic ossification.
Okay. What is your next step?
I would like to see any prior, if available, history of patient
For
um,
what?
for any trauma or any
Excellent.
previous surgery.
So what's your, give me some differential in management.
So this can be myositis ossificans. This
Hmm.
can be a calcified hematoma.
What else?
Uh,
Don't forget your MRI finding. See? Don't forget. What else?
this can be a parosteal osteosarcoma.
Excellent. What is your next step?
I will refer this patient to sarcoma center for biopsy and further management.
Thank you, doctor, so much. But take an advice for you. You have a good knowledge, but don't let the examiner ask you what else, what is your next,
Okay.
because you know. Okay?
Okay, sir.
Okay, doctor. Give the examiner impression that you are the leader of the case.
Okay, sir.
Thank you, doctor, so much. It was a very
Thank you, sir.
difficult case, by the way, especially there are no contrast. See, my colleague, this is the attitude of the exam. Sometimes the examiner will not bring you, provide you first with the X-ray. No, he will give something like this. MRI with mass, and really the mass looks like with the degeneration size looks like sarcoma. But don't forget the standard procedure. In any MSK MRI, you should ask for X-ray. Why? For calcification, not for anything else. For calcification. When I present the X-ray, the differential change it totally. See, nearly totally calcified mass. So our colleague started to think about myositis ossificans or whatever any other type of heterotopic calcification. But if you didn't ask, the examiner will not give you. And finally, you will give for a benign case like this as a sure sarcoma from your side. Second, you should ask for the history. So all of us, we should take a home message today. All patient, we should ask for previous examination and history. Especially MSK patient, ask for a history of trauma. Okay, my colleague, this patient has been biopsied because they are, يعني the radiologist have a big doubt about the two differential, but finally it was diagnosed as myositis ossificans. My doctor, can I ask you one question, please? Last candidate,
Yes, sir.
can I ask
Yes, sir. Yes, sir. Yes, sir.
how to differentiate between parosteal osteosarcoma and myositis ossificans? What is the differential point?
So the differential point in myositis ossificans, there is a central lucency and peripheral ossification. And
Yes,
in perosteal osteosarcoma, there is central ossification and peripheral lucency, as in this case.
yes, thank you. She means the calcification start at the periphery in the myositis ossificans and start
Yes.
at the center in the sarcoma. But if you look at this case, this is borderline. Really, I can't judge where is the maximum calcification. So the patient was biopsied. Thank you, doctor, so much. It is a case of myositis ossificans, but if
Thank you, sir.
you told the examiner both differential, he will be happy. Next candidate.
Yes, sir.
Can you request control, please, doctor?
I'm not able to.
Okay, 64-year-old male patient
Okay, sir.
complaining of abdominal epigastric pain. He has
Okay, sir.
a chronic epigastric pain for 3 months, and then he or she, I don't know, he developed sudden severe epigastric pain. Go on.
Okay, so I'm provided with the axial contrast enhanced CT images of the abdomen in a patient with a history of epigastric pain. The first thing that has struck my eye is I'm seeing there are free foci of air suggestive of pneumoperitoneum, predominantly in the perihepatic region and the region of the anterior abdominal wall. There is some free fluid suggestive of ascites in the perihepatic region as well as in the perisplenic region.
Yes,
Uh, the visualized extent of the pancreatic parenchyma appears unremarkable.
yes. What
Um,
else?
Sir, can you please scroll a little cranial and then caudal if possible, please? Can you just scroll through the whole sack at once, sir? The whole series, please?
I'm trying to help you. I'm trying to
I'm
concentrate
actually able to
on
see
the
that there
event.
is a possible
Yes,
communication between the duodenum, the third and fourth part of the duodenum, with the stomach at this point where you have stopped. And there are some foci of extraluminal air around this as well.
excellent. Yes. So
So I'm
what do you think?
possibly
What do you
a
think? What
fistulous
happened here?
communication. This is probably a
Okay,
fistulous communication.
not fistulous because there are no communication. See the stomach here. This is the stomach.
Yes,
There are
yes, sir.
no the stomach end, and then this part started. No fistula. What happened here?
So probably there's a perforation of the duodenum, and
Okay.
there's a sealed off perforation with a localized collection adjacent to it.
Excellent. Which part of duodenum? This
This is probably the fourth part of the duodenum.
excellent. Okay. What else? So what's your diagnosis?
So my diagnosis would be a hollow viscous perforation secondary to a perforation at the fourth part of the duodenum, with intraperitoneal free air suggesting pneumoperitoneum and some minimal ascites. So I would take a look at the rest of the abdomen to scroll down just to make sure there is no evidence of any perforation elsewhere. And I would ring up the
Concentrate
referee.
on upper abdomen. Don't worry about the lower abdomen.
I'm also seeing
Okay?
that in the lung basis there is some subsegmental collapse slash consolidation.
Okay. Okay. Okay.
Visualized liver repairs.
Why is this part perforated? Why? In this age, the perforation almost secondary. Okay? This
Yes, sir.
patient, by the way, has no history of trauma. So, what is the cause of perforation?
So it's a hollow viscous perforation. So I would want to rule out if there is any ischemic cause for it.
No any ischemic cause. What else?
Mm,
Look again.
any history of inflammatory bowel disease prior?
No. What else? This patient, I will help you, but in exam
Yes.
you should remember well the history. Have a chronic epigastric pain and then sudden severe epigastric sharp pain.
So
What are you thinking? What?
any prior history of pancreatitis or any gallbladder stone?
Okay, I'm scrolling for you. This is,
Yes, sir.
I think, scrolling for you and stop
I'm not
me
seeing
at
any
any
intrahepatic
important.
biliary radical dilatation.
Don't
I will
worry
just
about
take
it.
a look to see if there is any stone in the CBD or in
No
the
stone.
pancreatic duct.
No stone. Mm. What about the pancreas?
The pancreas is looking a little bit of, there is a fatty atrophy of the pancreas, but I'm
Okay,
not
what
seeing
else?
any obvious, there's no obvious
What else?
dilatation of the pancreatic duct. There is a focal calcification, a soft tissue
Yeah,
density with focal calcification in the region of the proximal, um, most likely the head region of the pancreas.
what do you think? What's your provisional diagnosis?
Could it be a adenocarcinoma? But I'm not seeing any double duct sign to give me an evidence that there is an
We
adenocarcinoma.
we have perforated duodenum and we have a small calcified pancreatic neck lesion. So what come in your mind first? What is the different types of pancreatic tumors?
So we have the neuroendocrine tumors, which would be hyper enhancing on the arterial phase, or it could
So
be.
you think this is neuroendocrine or adenocarcinoma?
I think it's more of a neuroendocrine tumor because if it was an adenocarcinoma, I would see a double duct dilatation, which is not there in our case.
And okay, which type of neuroendocrine that cause perforation?
I'm not sure about that, sir.
Gastrinoma, insulinoma,
I think it's
glucosamine.
gastrinoma because of the hypersecretion of the gastric content.
Okay, excellent. By the way, it is a difficult case. Why? I told you many times before, take care so much. Be so carefully in old age of the pancreas. About the pancreas, what it is atrophic pancreas. So any lesion, really, it is difficult to pick up. This is not normal, by the way. This part should be like this, infiltrated
Yes,
by
sir.
fat, but looks like back the cell, something like this, and calcification. What is your next step?
So I would immediately inform the referring clinician of the emergency finding that the patient has a pneumoperitoneum and he would need an emergency surgical intervention. I would
Excellent.
also discuss
But
further refer this
before
patient.
see, before they will take the patient to OT, they must know, make sure this is gastrinoma or not, because if this gastrinoma, they may treat surgically in the same set. So, what is your next examination?
I would want to refer the patient for a octreotide scintigraphy to confirm if the patient
أيوة.
is having a.
Okay, look here.
Yeah.
What is this?
So this is a MRI image of the patient. Is it the same patient, sir?
Yes, yes.
Okay. So
But this
I'm
is after
provided with.
6 months, by the way. 6 months later.
So I'm provided with the axial MRI diffusion weighted image of the same patient. I'm seeing that there is a hyper intense lesion in the left
One could,
lobe.
how could you simply know this is a diffusion? I will help you. See my
Yes.
colleagues. You will not see spleen like a light pump like this in any MRI sequence apart from DWI. Frankly, look at the
Yes.
spleen, very, very bright. And the lymph node, by the way. Lymph nodes and the spleen, but as the spleen is a large or solid organ, it will be really looks like your car light bulb. Number two, you will not pick up the fine details, anatomical details. I told you many times before, functional MRI sequences will not show you the fine anatomical details, and you should tell yourself, oh, this is a functional MRI sequence. Whatever. When you see a spleen like this is a diffusion. Tell me your
Yes.
finding, doctor.
So I'm seeing a fairly well-defined hyperintense nodular lesion in the left lobe of the liver,
Well,
probably the segment
okay,
3. So I'm
let's
suspecting this
have,
could
okay,
be a metastasis. I would want to see the
yes,
ADC maps to see if this lesion is showing diffusion restriction.
I will show. But what else? Could you have a look at the pancreas, please? What is
Yes, sir.
this? Could you find anything?
So can you just scroll again, please?
At this slice, this is the pancreas. Uh, Look,
I'm able to appreciate there's a focal diffusion hyperintensity in the central region of the pancreas.
in the neck. What else? Could you have a look at the tail?
Also, there is a focal hyperintensity in the region of the tail of the pancreas.
Excellent. I will show you in the CT. Look, this one.
Yes, yes, sir.
This is
There
the
is a
tail.
similar
What?
lesion in the tail of the
Yeah,
pancreas. So
this
these are
is
multiple gastrinomas.
so two calcified lesions, which both of them show diffusion restriction. By the way, to save your time, it is a low EDC, so it is true restriction. Yeah, give me a diagnosis.
So this is multiple gastrinomas in the region of the pancreatic head as well as the tail with liver metastasis. So most likely a metastatic lesion in the liver. So I would want to find out from the referring clinician if the patient is having a Zollinger-Ellison syndrome.
Yeah, sure, sure. This is Zollinger ellipsis because it causes for the patient perforation. Okay. What
Yes, sir.
else? In multiple gastrinoma, what is your doubt? What do you want to search for, doctor? Can we take the next candidate because this case is very long? Thank you, doctor. You did very well. It is very
Thank you, sir.
difficult case, but we are covering all the possible cases related to exam. By the way, my colleague, I get feedback, I think, from 6 candidates who go through the last zone, and all of them mentioned that you must get at least one atypical, totally atypical case. That is the aim of most of my session, to cover the atypical, the difficult, the part that you can't cover by yourself. Next candidate,
Thank you,
مساء
sir.
الخير.
hello,
مساء الخير يا دكتور.
welcome. Doctor, this is the same patient, um, and he has two pancreatic focal lesions and يعني aforementioned CT was diagnosed as perforated duodenum. Our last colleague, her differential diagnosis, this is gastrinoma and Zollinger-Ellison syndrome. But this is multiple, two more than one tumor foci focus, you can consider multiple. What is your doubt when you find two or multiple neuroendocrinal tumor? What are you thinking about, doctor?
Well, first I will try to find if any focal lesion in the liver or no. Second, I will see if any associated with Men's syndrome.
Excellent. Thank you. This is, see my
It
colleagues,
means that
any
men
examiner
one.
want to listen one buzzword. You should exclude Manson syndrome. Excellent. What will you do? Hello?
I yes, I will
What
try
is
to
your
ask
next?
about. I will try to
Yes,
ask about if any patient has anything in parathyroid hormone and request ultrasound neck to see if any lesion in the parathyroid. Also ask about any symptoms of brain about pituitary because main one affect pancreas, pituitary and parathyroid hormone and parathyroid gland.
brilliant. Okay, radiologically, what will you do? The patient
Ultrasound neck,
underwent a
ultrasound neck,
laboratory.
MRI brain.
One second. The patient underwent a laboratory investigation, and there are some hormonic disturbance. So, and you mentioned you will do ultrasound neck, and what else?
MRI brain to see if any lesion in pituitary gland.
Brilliant. Really, really, I'm so impressed. My colleague, the second step is very important because in NHS, the radiologist is the leader of the treating process, even in the MDT. Look, I think what is the MRI? Last one. You can go through
I'm
this one, doctor. Okay, what is this?
okay. Doctor,
Yes,
you will screen for me.
yes, yes, yes.
Okay. I am presented with the MRI G2 sagittal. I will scroll from first to last cut. I can see 1 minute.
MRI of what, doctor? What is the name of this exam?
MRI brain sagittal.
No, not brain. Not brain because most of the brain is out of the field.
This for
MRI about
pituitary
this?
gland.
Yes,
Cella.
sure. Thank
Cella
you.
and the pituitary
Yes,
gland.
Ella. Okay. Okay.
Yes. I will scroll. Um,
See, I will help you because
okay.
what is the most important sequence in Cella?
I want to see
Hello?
with contrast. I can see I can see a well-defined small hypo-intense lesion in the cella. Uh,
Okay.
this one, maybe this one microadenoma. I want to see if is this one affect the chiasm or no. As both internal carotid show a
Here.
signal
Look.
void good
One
and the
second.
normal caliber not affected.
One
I want to
second.
see
Look.
delayed contrast and delayed.
Look here. What happened here? Could you find any contrast abnormality or discrepancy? Yes or no?
هو little decrease caliber of the right internal carotid.
Don't worry about it. I'm talking about the pituitary. Did you find any contrast abnormality over all the pituitary?
No, can I see delayed?
What is the best? Okay. Tell me about this. Did you find any abnormality here? By the way, this is post contrast as regard radiopedia. Did you find any abnormality? Compare this side with this side. Did you find any
Only
abnormality?
enlarged, only minimal enlarged in the left side of the pituitary gland, but no
Excellent.
affection of
Excellent.
the internal carotid artery caliber or signal.
To diagnosis,
Pituitary microadenoma. I want to see in delayed if this one
why
take
not
contrast.
macro? Why not macroadenoma?
I think this one less than 10 millimeter.
Okay, excellent. So this is a microadenoma. So give me your final
I
diagnosis
will
about
con
this case.
Okay, I will convey my finding to referring physician and refer patient to endocrine and gastrointestinal MDT urgently because the perforation in the duodenum, and also a lab test for prolactin and hyperparathyroid calcium phosphate level. Uh,
Excellent. My question here, what is the best technique for MRI pituitary? What is the best technique? What is the name of the exam or the technique itself?
Pituitary technique delayed contrast and delayed also.
Like, okay, but it has a more specific name.
I don't know. I'm sorry.
Dynamic. Dynamic.
Dynamic, yes, yes, dynamic.
Yeah, dynamic. Okay. It is better
Okay.
to see pituitary. What is, my colleague, what is the mean of dynamic? Because we use it in MRI liver. This means you are taking, you inject the contrast. And after about 30 seconds, exactly, this is the arterial phase. Even from the second 25, you start to take sequence. Why? Because there are interpersonal differences between the patient. The ideal protocol to take the arterial is about if early arterial, 25 late arterial, 35, like this. But there are interpersonal variation. So dynamic take as a general rule any dynamic study. Means there are many sequence are taking after the second 25 second. The machine take many. So you can see, for example, in liver or in the pelvis, female pelvis, in sequence, the technician may take 20 sequence only of contrast. This is the dynamic. And you as a radiologist, you must choose the best one according to the patient and according to your eyes, and you should know the timing. Each sequence mention within it the timing. This is after 30 second, 40 second, 35, like this. Okay, this is clear?
Clear.
Clear, doctor?
Yes.
And sure, you will get the timing 60 second. This is the venous, and then the delay. Sometimes some technician write this is delayed especially. Okay, يعني make the delayed as a different a separate different entity. But dynamic for arteria, this is the purpose because there are patient variation. So it was a hypo-enhancing lesion here, causing a little bit contour bulge. There are many signs of macroadenoma will be obvious for all of us. Contour bulge, hypo enhancement. T2 is very important. T2 high resolution. Do you know, doctor, what is the mean of high resolution T2?
The mean of high resolution T2
Yes.
uh, to see the vessel and signal void in the vessel.
Yeah. How we get the T2 high resolution in any part, pituitary, rectum.
I don't
High
know.
resolution means thin section. Thin section. For MRI, the thin section is about 3 mm, and they decrease the gap. But in MRI, we can't cancellate the gap. We can't. There must be a gap, but is a minimal gap between slices and the minimal thickness. It will give you a high resolution. Why? High resolution in pituitary and in rectum is very important for fine details because look, the organ itself is very small. So in pituitary, the high resolution T2 is very important. The dynamic post contrast is very important because it is hypo enhancing. Why the pituitary adenoma or microadenoma is hypo enhancing? Because it is an adenoma, not sarcoma, as a general rule. Okay, my colleague, all of these are general rules. It's very important. Exam maybe, يعني, maybe asked in the exam. Expect everything. So we are trying to cover. In microadenoma, okay, this is good from you to talk about abutting the carotid, but this is micro, not a big deal. The most important to pick up. Thank you, doctor, so much. It was a very fantastic case. I will show you the diagnosis here to all of
Thanks,
you.
doctor.
Thank you so much. See my colleague. Men type 1, multiple endocrinal neoplasia, type 1. There are type 2A, type 2B, or type 2, type C, whatever. But the most important is type 1 due to Zollinger-Ellison syndrome. And this is the typical presentation. Patient with perforated duodenum, surgical emergency, and all of us almost we will miss the most important point here, this lesion in this atrophic pancreas. Okay, this is the cornerstone of this case. Thank you, doctor, so much. Next candidate.
Assalamu alaikum,
Next
sir.
candidate. Alaikum salam.
Sir, should I
Doctor,
ask for
this,
the control?
yes, Dr. Omer, ask.
Yes, sir. Okay, sir. Yes.
My colleague, I wanted to, يعني, to send a special thanks for Dr. Omer. Really, he helped me in each session. Really, really. Thank you so much for your effort, Dr. Omer.
Sir, thank you. Thanks to you, you always take out time for us from your busy routine. So thanks to you too.
Really, without our coordinator, especially Dr. Omer and Dr. Nagam, really more than 50% of these sessions were about to cancel. Go on, Dr. Omer. This patient have a heavy menstruation, but now she has about 3 or 4 months of heavy menstruation, but now she came to you with sudden severe abdominal or pelvic pain.
Okay, sir. I'm presented with the MRI pelvis, and these are the T2 sagittal images in which I can appreciate that well-defined rounded hypodense mass lesion is noted, which is intramural and seen along the anterior uterine wall. And I would examine the rest of the uterus. The posterior wall is unremarkable, and tiny other hypointense lesions are also noted. And sir, I would also try to take a look at the adnexa, and sir, and I would confirm my findings on the axial T2 axial images.
Okay. Take whatever you want.
Okay, sir. Okay. Okay, sir, these are the T2 axial images, and now I will scroll from down and I'll scroll upward. The cervix is unremarkable, and then as I scroll upward, I can appreciate that. Uh, okay, so bilateral ovaries are also unremarkable. The right ovary shows few follicles, and uh, okay, so a large uterine fibroid is again redemonstrated with multiple small tiny fibroids are seen, and I would like to confirm my findings upon post-contrast images. And sir, as the patient has presented with acute pelvic pain, so I have to look for the other causes of the pelvic pain as well. And there is also indentation over the endometrium, mild indentation over the endometrium is noted as well. And I cannot see any free fluid in the pelvic cavity. And sir, I would like to review the post contrast. So can I open the post contrast?
Take the post contrast. Why? But
Okay.
before you start in post contrast, why you wanted to have a look at post contrast?
So I want to look at the enhancement, and to also look for any degeneration, necrosis in the fibroid, and is it enhancing or not, and any other lesion, any other sinister lesion which I can see, which could be the cause of the pain in this patient.
Okay.
Okay. Okay, so these are the post-contrast images, and okay, sir, I'm scrolling these images, and I can see that there is so there's a peripheral enhancement noted, and I cannot appreciate any central enhancement. Sir, I would like to review, sir. Sir, can I see the diffusion images to look for any areas of restricted diffusion?
Look at the diffusion, Dr. Omer.
Okay, sir. Sir, okay. Sir, these are the diffusion weighted images, and I cannot. Okay, there are a few hyperintense area upon DWI, which I would confirm on the corresponding ADC whether they are restricting or not. So these could be representing myxoid degeneration in the fibroid, which can be leading to acute pelvic pain in this patient.
Do you think myxoid degeneration cause acute pelvic pain?
Sir, it can be one of the cause, because I am unable to see any other cause in this patient, because there is no definite acute restricted diffusion, there is no free fluid, and the ovaries are also unremarkable. So I have to determine some cause of the acute pelvic pain.
You have one sequence. If you look at it, you will get the finding. The sequence
Okay,
that
so
you are not asking about at all.
sir,
Only one sequence.
okay, sir, I am left with the MIP images only.
Whatever. I will not tell you because, by the way, this case is very not difficult, but a case of procedures, searching procedure. Which procedures that are you using? Are you following the NHS protocol or not? One word.
Hmm,
If you follow, you will get from the first slice. Hmm.
okay.
Which
Uh,
sequence?
Sir, to look for the hemorrhage, I can see the T1. Okay. So these are the, I'm going to scroll them. Okay, sir, these are the T1 images, and sir, it is appearing hyperintense upon T1 weighted images, and
So, so
sir, this could represent some hemorrhage or some blood products or high proteinaceous material within this, or changes of myxoid degeneration within this fibroid.
see, no. Myxoid degeneration almost chronic, not painful, and you will see fluid-like spaces. One word.
Okay,
I'm talking about fibroid. This is the usual
okay,
what we see in our routine practice. It looks like the normal cystic degeneration. But
yes, sir.
what is high T1 in fibroid? See, Dr. Omer, this is high T1 in fibroid means only one issue.
Sir, red degeneration, or
Finish.
sir, hemorrhage, acute hemorrhage with bleed within the fibroid.
Okay, acceptable also. Any of them is acceptable. Thank you, Dr. Omer.
Okay,
By
thank you,
the
sir.
way, all of us, even me, skipped one. Not Dr. Omer. All of us. And that is why I bring this case. Okay. My colleague in MRI is T1 is very important for two critical issues. Number one, hemorrhage in any organ. Number two, anatomy. This T1, what is the name exactly of this T1, Dr. Omer? This is not a routine T1. Look here.
So this is
This is
T1 fats.
what
Okay,
is vibe?
fat set, yes, sir.
Yeah, what is vibe? Vibe is a technique, I think, like Dixon in liver. It gives you a better image detail. Why? Because it looks like 3D. Really look
Okay.
here, the fine details looks like very, very obvious. Why? Because they use some techniques that gives the image more better due to 3D techniques.
Reconstruction resolution. Yes.
Dixon in liver and the vibe in pelvis. Okay, what happened here?
Yes.
This is the site of fibroid. This is the T2, this is the T1. Okay,
Yes.
and the patient is in acute pain. Despite the red degeneration is very common in pregnancy, but it is not limited to pregnancy. Okay, so like Dr. Omer said, it may be hemorrhage or it may be whatever red degeneration, but there are an acute cause. We pick up the cause of acute pain. Dr. Omer, what happened in red degeneration? Could you give me a brief?
Sir, causes of
What happened
uh,
in degeneration?
sir, this is basically the fibroid. Sir, it overgrows its requirement.
So,
The nutrition. Sir, so the necrosis starts in the
okay,
fibroid.
but not that before necrosis, there are something else.
So the blood supply basically it reduces due to its
Compromising.
overgrowth.
Okay. Okay.
Yes.
Compromising of the blood supply with subsequent infarction. So the
Yes, sir.
patient presented with acute pain.
Yes, sir.
Why commonly in pregnancy due to the hormonal, the
Hormone
heavy hormones
imbalance.
during pregnancy and the growth of the uterus, even the fibroid itself increase in the growth. Okay, but finally, the blood vessels may be occluded, may be compromised, causing infarction and the subsequent regeneration. Okay, my colleagues. So it is very important to have a look first at T1, then T2. I think in fibroid, contrast is not the most important sequence to look for. Contrast is very important in ovarian masses, carcinoma, deposit like this. Thank you, Dr. Mir, so much. Next candidate. Next candidate. Hello?
Dr. Bushra, please proceed from the extra list.
Okay, hello.
Hello?
Can you hear me?
Yeah.
Hello,
Doctor,
can you
this
hear
is,
me?
yeah, request control. This 40-year-old female patient presented with 3 days of abdominal pain.
40-year-old patient with 3 days abdominal pain.
Yeah.
So these are contrast-enhanced axial CT sections of abdomen and pelvis of a patient, 40-year-old patient having history of abdominal pain for the last 3 days. I'm scrolling from top to bottom. There is a moderate amount of ascites. Further going down, the liver shows normal opacification. I'm looking at the pancreas. The pancreas also shows normal enhancement of its parenchyma, the spleen. Yeah, I am suspecting some non-enhancing areas in the spleen. However, I would like to confirm this on the delayed phase. Further going
Okay.
down, the adrenal. Sorry, I am going up. Sorry. There are also bilateral pleural effusions with adjacent basilar atelectasis. Sorry, I was going up. Further, going down, the both kidneys are taking the contrast normally. Aorta is also normal. I am looking at the superior mesenteric artery. I think, yeah, superior mesenteric artery and the celiac axis. They are also normal. Um, Further going down, the gallbladder is distended and it shows enhancing walls.
Don't worry about
The
the upper abdomen. Please go lower, more lower, please.
okay, I'm going down. Okay, in the lower abdomen, there is
Go,
enhancement. There are dilatation of the small bowel loops
go
that
again.
also show enhancement. in the mid and the right side of the abdomen. I'm going down further. Sorry. Okay. Okay, I'm looking to see the cause of the bowel obstruction.
Doctor, did you miss any critical findings?
Yes, sir. I think I missed a critical finding. There is also pneumoperitoneum. However, I would like
Yes,
to see this on the lung window. There are also
yes.
multiple free air
So,
also seen, multiple pockets, small pockets of.
so do you,
So I am suspecting bowel perforation, and this is an
yes.
emergency, and I would urgently inform the findings to the surgical team. However, I also need to see the transition point and also the point of level for the bowel obstruction. I think this is
Go down, please. Go down
also
if you want to see. Go down. Down.
okay. Okay, in the pelvis, I'm looking the hernial orifices are intact, and in the pelvis, the this is Foley's catheterization. This is the balloon in the urinary bladder. These could be due to adhesions or due to inflammatory bowel disease because I was suspecting multiple enhancing loops of the bowel in it. Um, in this region of the cecum, I'm suspecting some defect along the right lateral wall of the cecum. I'm not sure. So, so in summary, as I couldn't see the exact level. I was suspecting at the level of the cecum some points of narrowing. Also right over here in the region of the right lower abdomen. There is some stricturing, and also I'm suspecting some high density foci within it. So cause could be some gallstone. I guess I also need to look again at the to see the status of the gallbladder. However, anyways, this is an emergency and this needs urgent surgical referral. Further going to
In
the
case like this,
gallbladder.
doctor, in case like this, there are
Yeah.
signs of perforated viscous, and you didn't pick up at the X-ray. What is your next step? What will you do? Because the surgeon wanted to know the site of perforation to repair it, either it
But
clonic,
also I would like
duodenal.
to see on the coronal imaging. I would also like to see confirm my findings on the coronal imaging
Okay,
to further see the exact
this is the
level of the
coronal.
perforation.
Yeah, let me scroll for you to help you. Let me.
Yeah, yeah, because I think the mouse, there was problem with the mouse. Okay, these are contrast
What
enhanced
is,
coronal sections.
1 second. The patient is 40. Yeah, not elder patient. Yeah. What do you think? Where is the maximum? Where is the site of the perforation?
So I think there are also, yeah, is this not this is a large vowel, and also I think in the right over here there is maximum enhancement, and also sir, can you please scroll up? Is this also? I think this is
See, what is this? At least, when you want to search for a
this is
site of
Foley's
perforation,
catheterization. So this is Foley's catheterization. I need to see
you want
its exact
listen to
location,
me.
whether it is in the.
Listen to listen to me, please. When you want to search for site of perforation, you should keep something in mind. What is in your mind now? What is the indirect sign?
So there should be a small bowel fecal sign, and also I think, and this is I was suspecting right over here, and also
for
pocket of hair.
Look here. Look at the sigmoid colon. What is this?
Yeah, there are divertically. There are also divertically formation and also
What?
thickening.
And the colon itself is thickened. Okay.
Yeah. Yeah.
Look, diverticulosis, and look here. If you look here, it looks like some extra luminal gases. So
Yeah.
look here. Look at this side especially. See, if you look here, I think this is a defect. So where is the defect?
Then in the sigmoid colon, yeah, on the right side, along its right wall of the sigmoid colon.
Okay. Thank you, doctor, so much. What did we have learned from this case? Number one, your eye in the abdominal CT, number one in pneumoperitoneum. Don't miss it at all. Don't be busy about the site finding normal like this. Like why? Because from this sign you will told yourself this is a perforated viscous. I should go number one for duodenal perforated ulcer. I didn't find any, and you are keeping in your mind the site of perforation. It has a sentinel lot and fluid and some air foci. Okay, this is the key in your mind. Okay, my colleagues, look down, down, down. We didn't find. But if we go here, there are some diverticuli here, many diverticuli and the thickening of the colon, and some surrounding extraluminal gases. At least you should tell the examiner doctor to make sure 100% of my diagnosis, I will give water soluble, water soluble enema, soluble. Okay? Any perforation, if you have a doubt about it, give oral water soluble contrast. Okay, my colleague, but if you are sure, no problem. This is all, my colleagues. It was an emergency. The patient, what is strange about this case? The patient is 40. Is 40. She or he is not an elder because perforated diverticulum is very common in elder patient. Okay, my colleagues. Thank you, doctor, so much. Next
Thank you.
candidate. Okay. Next
Yes, Dr.
is Doctora Nagam, please. Doctora Nagam.
Yes, sir.
What?
Hello.
Last case was perforated diverticulitis. Okay, my colleague, very important. Our great coordinator. Doctor, this patient has chest pain, and this is his chest X-ray on.
Okay. So I'm presented with the frontal radiograph of the chest of an
Yes.
of a skeletally matured patient. It shows
Yes.
a retrocardiac opacity, mainly to the left, multiple ECG leads. So this is a critically ill patient. There is a device projected over the right side of the parasternal region. This is I think it is like a ECG. I mean implantable cardiac defibrillator. Yes.
Okay. But have a look. Look, what is this? This looks like maybe outside. I don't know.
Okay. Okay.
At the
Okay.
hard film, what happened, Dr. Nagam?
Okay, so the
You still
retrocardiac
knows this?
opacity, also it is seen as external object. It is not
Yes,
obscuring any of the mediastinal structures, none the right,
yes.
the left heart border, none of the paravertebral lines. So I'm so much concerned about external structure to be repeat, the study to be repeat with removal of these objects to have better visualization of the lungs.
The patient
No
have
pneumothorax, no pleural effusion. Yes.
an echo and they find some abnormalities. So they do this examination.
Okay, so this is CT scan, coronal, soft tissue, mediastinal window. I would like to have a general look before starting my comment. There is a fat containing lesion seen in the
Excellent.
interatrial space.
Brilliant.
No enhancing component within this mass, no soft tissues, no septation, no calcification. So this is an interatrial lipoma. I would like to check the rest of the scan, looking for any other acute findings, which is not there on this slide. No pleural effusion, no pericardial effusion. The vessels are patent, no intracardiac filling defect. So interatrial lipoma to be referred to the cardiology department for further assessment, management, and follow-up.
Thank you, Dr. Anagam. Really, really, your style amazing. Dr. Anagam
Thank you.
achieved a very good new standard style during this last vacation. Thank you so much. It
Thank
was
you
a
so much.
case, okay. It was a case of interatrial lipoma. Look, my colleague, this one, interatrial lipoma. Okay. What happened here? That Rex was here. When you are presenting with a case like this, either to ask for lateral or examine the patient, or this is the hard film. Look, it is very obvious an external object like a bat or a bat, and there are a wire here, and there are another one here. And I think this is external. Okay, it may be loop recording, something like this, but I think this is external. Why this wire is go outside? Okay, my colleagues. So all of this, by the way, this chest X-ray almost normal. Has no only just mild cardiac prominence like this. And what about the exaggeration of bronchovascular marking? This is due to the high KV. Okay, look here. Dr. Nagam, one question. How we judge the quality of chest X-ray? How
Okay, on
if
the
the
frontal view, I should see
yeah,
the intervertebral disc spaces through the cardiac shadow.
clearly see or just seen?
No, should be clearly seen.
No,
The
this is
intercostal, yes,
no,
intervertebral
no,
disc spaces should be seen through the cardiac shadow.
no. This is clearly seen here. This is hard film. This is bone film, age film. Okay, but we should see the vertebrae just seen through the cardiac
Okay,
shadow. And look here, really you can't see well the intercostal spaces here. I think this is the standard X-ray. But this is age film, heart film, bone film, whatever, because they increased here the KV. Okay, it was finally a case of interatrial lipoma. Okay, my colleague. Today, like or lipomatous hypertrophy of interatrial septum. Today, what did we do today? I presented about 6 cases, really very neat from the exam style. All of them, some of them contain emergency finding, subtle finding, observational finding, and the case of gynecology, it was a style, your procedure, very important. Okay. Take care, my colleague, from all of today advices. Hopefully, we will meet next Thursday again and again. Thanks for Dr. Omer and Dr. Nagam and for all of you. Thank you, my colleague.